Good morning, everyone, and welcome to our Interdisciplinary Health Research Symposium. And today the focus is on social determinants of health. We're pleased that all of you could be with us here in person as a hybrid event, and for all of those 200 and some plus who are joining us online. Thank you very much for sharing your morning with us. We have an illustrious group of speakers and poster presenters, so we look forward to hearing more about them today. What I wanted to share with you is a little bit about the format for today. So we're going to have speakers, then we're going to break into posters, and I will give you instructions on that, and then we'll resume and wrap up. So I have the distinct honor of introducing our Dean, Dean Lewandowski, who is here at the College of Nursing. She came here in 2017 and has assumed a variety of roles since her tenure here. So many of those have been added, and one of them is the co-chair of the President's UT Opioid Task Force. She also has added the roles of Vice Provost for Health Affairs for Interprofessional and Community Partnerships. And just recently, too, she was asked by the president to take care of the University Mental Health Response Team, the Social Determinants of Health Working Group, and also as a member of the University Pandemic Operations Committee. In addition, she was asked to recently assume the interim executive director position for University Health Services. And that's a key position to bring together all of the services that are provided for students, faculty, and staff here at the University of Toledo. I wanted to share with you a little bit about her background, and that is that she has been an associate dean. She's also been a professor at distinct universities, University of Massachusetts Amherst, to name one. She was also the assistant dean for family, community, and mental health at Wayne State University, just to the north of us. And she's held academic positions and posts at both Yale and at Johns Hopkins. Her research program focuses on violence and cumulative trauma in not only high-risk groups, but high-risk situations. She co-developed the Cumulative Trauma Scale. It's been translated in 6 languages and is used worldwide. She's also been the national leader in patient and family-centered care and has co-authored works that have helped change practice throughout the United States and world. She's a fellow in the American Academy of Nursing, and it's with great pleasure that I introduce Dean Lewandowski today. Thank you.
Thank you, Dr. Walsh, for the very complete introduction. It's great to be with all of you today. I'm really excited for this opportunity to share some of the work we've been doing here at the university and in the community in relation to social determinants of health. Increasingly, we recognize how important a lot of factors that we didn't really used to focus in on are in terms of really determining the health of our nation. So today we're going to really talk about some of those factors, how we can all really have a role in helping shape health in a very much more complete way. We're going to be focusing on some of the work of the University Task Force on Social Determinants of Health. This has been a really exciting group to coordinate. One of the things we found when we started working is that we have faculty and students in every aspect of the university, every college of the university, that are addressing some aspect of social determinants of health, as well as at UTMC. We also are so fortunate to have as our academic partners Promedica Health, and we're going to hear more in just a moment about some of the exciting work that Promedica is doing and why they're really national leaders in this area. And we're also going to get to see some of the exciting work of some of our students. So today's going to be a really nice way to focus in on other aspects of health that we really need to pay a lot more attention to, and I think they're getting a lot more focus. So we have a great group of people to help us look at that area today. So I'm excited to introduce our keynote speakers. They asked me to keep their introductions kind of brief, so I'm going to do that. We have Kate Summerfield, who is president of Social Determinants of Health at Promedica. In this role, she's overseeing the development of a 10-year, $50 million community revitalization initiative that will include housing and community development, job creation, and education. Prior to this appointment, she served as Promedica's Corporate Director of Advocacy and Community Impact. Kate and the Promedica Social Determinants of Health Institute are increasingly being recognized for their national innovative work in the community, and she and Dr. Sievert will be sharing more about that today. She's a graduate of Purdue University and earned a Master of Public Administration at Bowling Green State University. That's okay. I'm sure it was great. Next, we have also presenting as a keynote Dr. Dina Sievert. She has over 25 years of nursing experience as a critical care nurse and nurse educator, with 15 years of these in senior level management positions. Dr. Sievert is the Chief Nursing Officer of Promedica Acute Care, Ambulatory, and Providers, and also in the past year of much tumult and tumultuous times, became president of Promedica Memorial and Fostoria Community Hospitals. She has a Doctor of Nursing Practice degree from Ohio State University and a master's degree in nursing science from right here at the University of Toledo College of Nursing. She's also, because she's not busy enough, again, almost completed her PhD in nursing administration from Walden University. Over her tenure, she's helped to lead Promedica Toledo Hospital campus to 3 consecutive years of being awarded HealthGrade's Top 100 Hospitals, and in 2019, a Top 50 hospital. Dina has oversight of the Quality, Safety, Experience, and Clinical Risk Services divisions. In addition, the Promedica Center of Nursing Excellence reports to Dr. Sievert and is on a journey for advancing evidence-based care and culture, evidence-based care culture, there we go, and healthcare provider well-being. She serves on several community boards and participates in many organizations professionally. I'm really delighted to have with us today Kate Summerfield and Dina Sievert. I'll invite them to come and start our keynote.
Well, good morning, and thank you, Dean. Huge thank you to UT and for your continued partnership. Hope everybody has coffee. Also a huge thank you to everybody who's planning this day. It's so interesting that we've adapted to doing these type of what was in-person sessions, and now we're doing them virtually, and somehow we're managing. So again, a huge thank you again to UT, to the Dean, and to everyone who put this together. Also want to say a huge thank you to Dr. Sievert, my colleague. I was teasing Dina at some point. I'm like her hype woman. I don't know if folks saw on Friday or not. We announced that Gwen Stefani is coming to Toledo. Exciting. So I'm like the Blink 182 for Dina being Gwen Stefani. But again, a huge honor. Thank you again. Today we're going to do kind of a 2-part conversation. First, at a high level, we'll talk through social determinants and share both from a theory perspective, but also from a practice, some of the ways that Promedica is embedding social determinants, both into how we deliver care and think differently about our care model, but also how we're investing and doing work in community. So we'll talk a little bit about that, also around research and analytics, our framework, and some of the early findings that we found. And then Dina will be sharing more specifically around clinicians and how clinicians, as we both address social determinants for our patient population, but also the impact for our own mental health and well-being and the social determinants, both individually and a clinician. So that'll be the plan for today. Again, kind of a 2-part series here. So to get started, want to just spend a couple minutes talking about the evolution around healthcare. So obviously there's a lot of healthcare systems around the country. About 10 years ago, Promedica started to broadly think about how we define both our mission, but also how we think about health. And I usually start this slide. I get a lot of folks still, both in healthcare, in academics, and around the country that say, well, this is all great, but aren't you a healthcare system, right? Why are you active in housing? Why are you active in education or early childhood? And this really fundamentally goes back to how we think about health, how that's changing and evolving over both clinical care, but also how Promedica has changed to think about our mission. And so where we once may have talked about ourselves or thought about our mission as a health system, it's really broadened. And it's more about a health and well-being company. And that distinction is important as we get into talk about why housing, why education, why the deployment of things like economic development is incredibly important. So really broadly, again, health and well-being organization, and we'll talk more about why this is important, but also how this starts to shape how we invest and how we deliver care. So there's been a lot of discussion and research on life expectancy gaps. And so this is within a zip code or within a community, the difference in someone's life expectancy. Certainly COVID has exacerbated that. We've seen really strong differences. And even from New Orleans, one of the largest life expectancy gaps, this is in between neighborhoods, about 25-year differences, all the way down to DC. Interestingly enough, in the Toledo market, we see about a 22-year life expectancy gap, and that's from Sylvania or Ottawa Hills into the core district of downtown in some of our neighborhoods. So even in Toledo, we see about a 22-year life expectancy gap in some of our neighborhoods. And it starts to beg this question, well, why, right? Why are we seeing such differences when we have access to care, and why are there such differences in between neighborhoods? Part of that, and again, COVID really, we're seeing significant findings, both increasing life expectancy gaps, but it's also this recognition that it really comes to social factors. You can't explain some of the differences around housing or education if you also don't take a look at the health. And so it's really the social economic status and longevity. And we've seen this increase, which again is concerning. In the past year, there's been really fascinating and concerning articles where we're seeing this actually expand. And I'm certain over the next 12 to 18 months, as research continues to develop, we'll see more trends. But it's this overall view that the neighborhood differences, right, not necessarily clinical care, are really contributing to life expectancy gaps. And so if we zoom out kind of at a macro level, one of the things, and again, a lot of debate nationally around healthcare, both across the country, but also globally. One of the things that we're starting to see and really starting to recognize is that the United States, while we have great clinical access, we still have preventable deaths. We're still seeing concerns in the highest healthcare cost, lower life expectancy. And so certainly in this time in a global pandemic, as we start to reimagine and think and be forced to think differently about healthcare, the reality that the United States spends the most on healthcare, and yet we have some of the poorest outcomes of the developed countries, starts to beg this question, right? We see these life expectancy gaps across neighborhoods. Globally, the United States really is not positioned well in terms of cost and delivery of care as well. And so for Promedica, we started this journey to think about, are we making the right impact relative to our resources? We're about a $7 billion organization, and we've got a lot of assets, a lot of resources, people, and time and investments. But what's the difference that we're trying to make? And especially as we see that 22-year life expectancy gap in the Toledo market, are we really driving the right resources to the right things? And it's so about 10 years ago, as I mentioned, it started this journey led by our CEO, Randy Ostra, and our board to think about what are the things that are most important to our organization. We're a nonprofit mission-based organization. And so at the end of the day, our mission is to improve the health and well-being of our community. And so on the right-hand side, you'll see a lot of the things that traditional healthcare tracks, right, and are incredibly important. Revenue, market share, days cash on hand, right? These are the typical health system metrics. But as we look at the overall health outcomes, and that can be everything from life expectancy, as we talked about, to even thinking about things like universal preschool. What we see in the Toledo area is that only about half of the students in Toledo public schools are ready and prepared to enter kindergarten. And you fast forward those statistics impact on the health in the next 10 to 15 years, and you start to see direct correlations. So it really, again, started to think about what was the impact that we're trying to drive. Is it the size of our bed towers or the days cash on hand, or is it the health of the patients that we serve, the health of our employees, as Dr. Civic will talk about, or the health of our community as well? And so part of this, and you may have heard this term around anchor institutions, there certainly has been a lot of dialogue around this nationally. is this idea of anchor institutions that are mission-based, nonprofit, rooted in place. Often they're called beds and eds. So hospitals and universities, UT obviously as a strong anchor institution as well. We have a lot of resources, and how are we driving the resources as it relates to our people, our hiring? Are we thinking intentionally about hiring folks from some of the same neighborhoods where we see low life expectancy? How are we shaping our investments? Are investments driving economic development? Are they supporting minority women-owned businesses, our procurement? And so it really starts to shape how, for all of the anchor institutions really across the country, are we using our resources to drive the right outcomes? And what are those outcomes, and which should we be most focused on? The other concept, and you've probably seen this graphic before in maybe some of your classes, but is around social determinants. And so one of the things that's been interesting, and we'll share some research around COVID that we've done recently, but that healthcare, while it's incredibly important, it only accounts for about 20 to 30% of overall health and well-being. And that anywhere between 40 to 60, I think I just saw an article published that showed up to 70% of an individual's health is determined by social determinants. So the social and economic factors. What quality or type of job do you live in? What type of neighborhood do you live in? Do your kids, or do you have access to high quality education? What's the type of housing you live in, right? All these social and economic factors really are core to overall health and well-being. And so if you think back to the slides around life expectancy and the global healthcare status, if the United States spends the most on healthcare and yet we have the poorest outcomes, and yet we're also seeing that anywhere between 40 to 60% of health and well-being are driven by things like housing. Dr. Shetty, I think, will talk about some of the work that the Urban Affairs Center is doing around education, around economic development. It really starts to beg this question: are we focused on the right thing? And how do we start to begin to incorporate, as clinicians, as researchers, things like social determinants into how we deliver and think about care? And so about 3 years ago, as part of this work, again, we've been on a long journey, Promedica established a National Social Determinant of Health Institute. Like many healthcare systems and higher ed institutions, there were pockets of work that were happening. And it sounds similar to the task force that's been created at the university. We started to pull all of that work together and to think about how do we start to maximize the resources and the impact. And so the Institute was focused to really think about how, both at a community level, at a patient level, and also a neighborhood, how do we think more holistically about healthcare? It's not just what happens inside of our doctor's offices or what happens inside of our hospitals, while incredibly, incredibly important. We also have to think more broadly if we're going to curve the life expectancy gaps, if we're going to really start to shift where the United States is in terms of global health as well. And so from this work, there's a lot of different interventions and supports. I'm going to talk a little bit about how we're screening patient populations and how we've embedded that into our care. But it really comes back to two kind of broad categories. One is, how do we deploy resources and supports at both the individual or the neighborhood level? That may be things as we've screened for food insecurity, and we find that patients may screen positive for not having access to high quality food. We're actually prescribing food as medicine and writing prescriptions, again, at an individual or a micro level. We're doing a lot right now around job coaching and training, getting folks connected to high quality jobs. We know that living wage jobs are one of the indicators that really drive overall health and well-being long term. And so at an individual level, how are we identifying need? Again, patients, neighborhood, community members, and how are we connecting to the right services? And then more broadly, across neighborhoods and across communities, how do we deploy more population health level resources? So that's a grocery store. In 2015, we started to map all the food deserts in the Toledo market, identified a number of different, and actually deployed a grocery store. So today we have a full service grocery store that's located just outside of downtown. A lot around preschool. I mentioned that before. Toledo, of all the Ohio cities, Toledo is the only city in Ohio that does not have access and universal preschool. And so a lot of effort right now across the city with Toledo Public Schools, with Washington Local, with the city, with United Way, with the mayor's office, in trying to figure out how we create access to high quality universal preschool. Again, one of the indicators that we see from a research perspective is whether a child has access and enters kindergarten ready. We can actually track that to their overall health and well-being. So when we talked about, well, why is a healthcare system, right, focused on universal preschool, it really comes back to this broadening of health and well-being. And then finally, one additional example I'll just throw out. We announced a college promise in partnership with Scott High School, actually last year, right before things started to shut down. And so we provided access in partnership with the Keynote Foundation. Every graduate of Scott High School, which is an inner city high school in the Toledo area, heavily African-American population, every graduating senior had access to free college room, tuition, and board. We had about 13 of those students that graduated from Scott High School are actually at UT today. In addition, we provided support in a 2-generational approach to all graduating seniors and either their parent or legal guardian. So again, thinking more broadly about how health defines overall well-being and how can we invest differently. So here, and again, a lot of you may have seen from some of your classes, this graphic might be familiar, but both at an individual level, you'll see the food clinic or food prescription program as an example. Again, understanding individual need, connecting to the right services, but also more broadly, a grocery store would be an example of a more social and community network where that was a resource that we deployed. We're obviously measuring that impact over time. So one of the other things I just want to mention, along with the concept of anchor institutions, is this idea that place matters to health. And this is one of the things that healthcare has been on this long evolution of journey and understanding what this means and how do we start to divest resources into it. But certainly with COVID, I think it's become even more relevant that place, the physical infrastructure where people live, the neighborhoods, the playgrounds, the schools are really critical to our overall health and well-being of our patients. And so just like we have to be focused on providing exceptional quality clinical care, we also have to think about place and how we're investing as community in place, especially when you think about those life expectancy gaps. So I'm going to shift a little bit and talk more clinically and certainly the work that we're doing around identifying at a patient level or an individual level social determinants and how we connect to resources. So about, I think in 2015, again, we started to screen, first starting with our pregnant moms, led by Dr. Kent Bishop and our Women and Children Service line. We started to screen and ask pregnant moms that were coming in to get care from Promedica, started to ask a series of questions, things around, do you have access to food? Do you have stable housing? We started to ask these questions from really a sense of, is there a need? We know from the research perspective that there seems to be broad need, but how do we start to understand at a patient level? Since that time, we've started to expand, and now across all of our settings, we ask some social and economic factors. Every individual that comes in to get care from Promedica, we ask the 2 hunger screening questions. So whether you come into an urgent care facility of ours, whether you come into one of our senior skilled nursing facilities, you're asked these questions. We recently also expanded in the acute care setting as well. And so asking questions upon discharge, again, training and employment, behavioral health, housing. One of the things this has also been able to help us do is to track changes over time. And so our clinicians and our staff, our administrative staff have embedded these type of questions into how we deliver care. You'll see some of the stats here. So to date, and this is over a few years, we have about 2.6 million hunger screens. And so a lot of data. Overall social determinant screens about 192,000. We're also screening our employee population as well. And about half, a little over half of our patients that come in to get care have some type of need that have been identified. We have seen changes in this need over time, but the top needs, behavioral health, financial strain, food. Interestingly enough, with COVID, we saw social isolation actually popped for the first time. We had not seen isolation being one of the top domains, but we are seeing an increase in that. And then about 40% that have one need or having needs in multiple domains, right? So we're seeing some cluster around need as well. From a data perspective, we're also screening employers and employees. Dina will talk a little bit about how, as a clinician, how we need to think about our own individual social and economic factors and how we can support our own mental health. But we did a screening in a similar way across 3 different employee groups. All of these, interesting of note, all of these companies were good jobs. They were above living wage. And all the companies were in a growth period. And similarly, so we remember 55% of our patients are screening positive for some social and economic factor. For individuals who are actually in a job, and we have lots of folks that say, well, social determinants are only for low-income populations. But you can see in this example, about 50% of employed individuals, adults, are struggling to pay with basics like food and heat. 44% were food insecure, and about 30% reported having little or no purpose. That was a new question that we added. And so similar trends, behavioral health, financial strain, food, and purpose. And so the importance of this is that social determinants is not just for a specific population or a segment. Even in our commercial populations of patients, we're seeing need. Sometimes individuals present and we're not aware, but by asking the question, it can help us understand and provide care in a more comprehensive way. And so from a risk perspective, like again, lots of data, a lot of work happening in embedding this into our care delivery model. But we've started to say, okay, what's the impact of this? And how can we understand risk across multiple lenses? And so you'll see both, again, at a community level, starting at the top, an individual of someone living in a food desert, all the way down to an individual at a point in time when someone comes in to get care from us, how we're connecting to that and how we're understanding risk over time. And so there's both the social determinants of need in kind of the broadest category across community. There's also social needs, again, at that individual level as well. And so this is all great, right? We're understanding need, but what's the impact? And if we go back to the conversation around where the United States is in terms of outcomes and care, how do we know that we're actually making a difference? How do we know that we're connecting and actually changing overall health and well-being? And so we deploy a risk analysis where we both identify risk at an individual level. We look at the impact of that, and that is both clinically and across social determinants. So as an example, we're deploying a cohort right now in a diabetic population who's food insecure. So as an individual comes in with diabetes and they're connected to food supports, understanding that impact around diabetes care and food over time. Understanding where those results are, prioritizing, right? Lots of need, about 55%, as we saw, have needs. And so we have to get focused on where the direct needs are and then evaluate those results. What was the impact of the diabetic population as they were connected to food? Were there differences for those that were connected with food that weren't connected? And what were those relative to things like cost, outcomes, and utilization patterns? So a couple of examples I'll just end with, again, a lot of work happening from an analytics perspective. I'm going to show you 2 examples, again, from a research and a quality perspective of where we saw impact. And so this is around the food clinic program. And this is when an individual comes in to get care from us and screens positive for food insecurity. So there's a 2 hunger screening question that comes out of Boston Medical. A lot of health systems across the country are using it. If an individual were to screen positive for food insecurity, one of our providers then writes a script for food. So just like we would be prescribing food medication or another procedure, we're actually prescribing food as medicine. We have 3 food clinic locations in the metro area. They're co-located with our office buildings. In some of our other practices, we work with community partners in Defiance, as an example, where that food is actually deployed from a local food pantry. We have other models upon discharge leaving the hospital, we deploy food. So a lot of examples of different interventions, but this was specific for individuals who came into primary care, screened positive for food insecurity, and then were prescribed that food for medicine, and then received the prescription for 12 months. There were about 1,000 individuals that we analyzed, and what you can see here is a heavily female population. About 70% were female. Over half were African American. A high Medicaid population. Part of why we see a high Medicaid population is because of Paramount or Medicaid insurance. And so we're matching the clinical claims data sets along with our Epic medical records as well. And then about 43% were between the ages of 40 and 80, right? So high female, high Medicaid, high African American, and about a middle age population. And then you can see on the bottom left, I guess bottom right for you, about almost 50% had 4 or more chronic conditions, right? So pretty high hypertension, obesity, depression, and asthma. And what we were able to do, again, going back to the clinical model, we take all of our clinical data, we match that with our claims data set, we bring in commercially available data and purchasing data. And what we saw for this population, in the Medicare population, about an 18% reduction in ED visits. For the Advantage, which is our Medicaid population, about 11% reduction, 5% reduction in readmissions for Medicare, 6% reductions in medical cost. And you can see on the Advantage side as well. So one of the things that this is important as we go to payers and we start to make the case to payers of, hey, you know what, social determinants matters. It impacts healthcare costs. They say, well, that's great philosophically, but show us the impact to actually cost reductions. And it's this type of information that we're able to use with payers and actually negotiate contracts. And so today we have a number of different payers who are actually funding food, which again, across the country, not a lot of folks that are doing that at scale. The other impact I wanted to show you was around our Financial Opportunity Center. So we do free financial coaching. This is everything from individuals who are need their taxes to be done. It's just wrapping up tax season, so we've been heavily in a tax season, but also helping build credit, help get connected to scores. And so what we see here, about 50% or 80%, female. Again, some of the similar high Medicaid population, 65% had chronic conditions. And as individuals engage in financial coaching, right, and this is about improving their overall financial stability, increasing their resilience, about $400 average monthly increase about 30 points on their credit score. But then we use that same analysis and look at the impact to healthcare cost. We see about a 33% reduction in ED visits. This is using a matched, so we're controlling for both demographics. We're controlling for also other chronic conditions, as you see. Reduction in inpatient visits and actually an increase in primary care. And this is important because we're steering folks back into primary care. And so these are just 2 examples, again, as we understand need, start to connect to different individual resources at the individual and community level, and then we understand the impact over time, how this can ultimately reshape healthcare. I will share that we have just wrapped up negotiations for a payer, and a payer will actually be funding and providing on a contractual basis support for financial stability. So they're actually funding financial coaching, right? And so really important as we start to see changes in value-based care and shifts in reimbursement model, that payers are actually starting to pay attention, that as we have the data and the research that shows what the impact of social determinants is, that we can actually secure payment for this in the either value-based bundled payment or in this case, individual contracts for both food and financial stream. So I know that was a lot, a really high level overview. Again, huge thank you to the university and to your continued partnership. With that, I'm going to turn it over to Dr. Dina Sievert, who's going to share from an individual perspective things to consider for social determinants.
So all of the information that Kate shared is fabulous, right? We're seeing a lot of really good work happening in the SDOH world. And what I would like to do today is I'd like to just pivot a little bit and take that focus and put it back on the clinicians that are the ones that are in those frontline positions every day, encountering these patients and what that impact has. You know, I think that we've gotten to a point now, some of us would argue that we've been doing SDOH for a very long time. You know, I know that in nursing, in my curriculum as when I was a very young new graduate nurse, you know, we talked a lot about the holistic patient and thinking about these things. But I think what has been missing is what Kate and her team and others are providing, which is kind of that structure and those processes and really pulling it all together to make it a concept in and of itself. And I think that that's where our power is in regards to making this concept, moving it forward in our discussions. And, that's all wonderful and great because we're changing patient lives, which is what we really want to be doing. But with all of this work, because of not really having these things in place over the last decades or for all of healthcare, one of the things that we're beginning to see or that we're understanding is that this is also impacting our clinicians. And so that's what I want to talk about today is how is it impacting our clinicians? So we've all heard the stories, right? The patient that comes in to see their primary care physician because of a problem that they're having. And the physician wants to order, medications, but that patient has to make the choice between going to see that primary care physician or getting that medication prescription filled versus putting food on the table for their family for the next couple weeks. Or the high-risk pregnant mom who cannot make it to the prenatal appointments because she doesn't have a reliable form of transportation. Or the young woman who comes into the emergency department for a broken arm. And when that nurse or physician is performing that assessment, we see that she's got multiple bruises that are healing all in different stages. And this young woman's not making eye contact with the clinicians. And her story of how that broken arm happened really isn't adding up. So we hear these stories continuously in the hallways of all of our institutions. But what are the stories that we're not always talking about? What are the stories that we don't hear? So that young new physician who's now struggling because she knows that the patient probably cannot pay for those medications that she has to order. And she doesn't really know where to go with that. She doesn't know how can I do this? How can I get this patient what they need? Or the worried dietitian who has now placed several phone calls to that pregnant mom who needs help managing her pregnancy-induced diabetes so that we can avoid, infant demise. That impact because she's worried about her and she's worried about the baby. Or that defeated emergency room nurse who recognizes this young woman because it's now several times that she's been to our emergency department. And he knows in his heart that these injuries are not because she's just clumsy, as she says. And so, guys, when we talk about our clinicians and their well-being and their mental stability and their mental health, this is a game that we're not doing well in, and it's coming to the end of the game here. And we've got to start thinking about how are we going to help them? How are we going to play with what's our strategy going to be successful here? And, I'm a huge Simon Sinek fan. If you don't know him, I would highly recommend that you do some reading with him. But, one of his quotes is that we can't change the game and we don't get to pick the rules, but we do get to choose how we can play the game. And I think we're doing a really good job here in all of the work that's going on around SDOH. So let's go back to why clinicians actually get into what they do, right? What drove you into the work that you do today? Well, we all want to help, right? That's one of our basic fundamentals. We want to help people. We want to cure people, maybe. We want to help them heal. We want to be the change in this world to make it better. We want to grow professionally and personally. We like to be there for other people. That fills our cup. That makes us feel good. And again, just to make this a better place. We're all very altruistic. We're sacrificing people. We believe in beneficence and non-malfeasance. And these are all things that pulled us together and drove us into the professions that we are in today. But let's face it, guys, we tie our clinicians' hands here, right? Our healthcare system, and Kate alluded to this, isn't built upon a wellness model. We're still very focused on episodic treatment and treating the disease as it comes in the door and not thinking about all of that work and that needs to be done on the SDOH realm. And so really, when you think about those frontline clinicians that are out there every day, their hands are tied. They can't always make these connections. They don't know these resources. They don't know how to make the patient's social determinants of health better. And what does this result in for these clinicians? So a lot of these are catchphrases that you've probably seen if you've picked up any type of healthcare journal in the last decade. I'm sure you've seen all of these. But this all results in moral injury to our clinicians, burnout, depression, anxiety, stress. it can translate into disruptive behaviors. Being a nurse, being a nurse, one of the hot topics in nursing and what we're known for is that nurses eat their young. We have a ton of lateral violence that exists. And a lot of that, when you trace that back, comes down to that unmet need, that personal fulfillment, right? Some of it is, not all of it is, but certainly some of it can be related to that. And what about compassion fatigue, right? That's a very real thing that we're dealing with today, particularly post-pandemic. You hear about this so much now where our clinicians are just, their cups are empty and, where they can't be empathetic anymore. And it's hard to build that compassion because they're not fulfilled right now. And a lot of this also then translates into some of the horrific things that we're seeing, significant substance abuse issues, and then also suicide rates. And we're going to dive down into these things just a little bit more. So today we know that some of the research demonstrates that 50% of our physicians are burnout in their day-to-day activities. We know that for nursing staff, it's right around 16%. So maybe not as bad. But here's the scary part of that when you take it just a step further, is that the job market is anticipated to grow for nurses by another 15% by 2026. Folks, today we have a nursing shortage. We can't meet all of the demands. We have thousands of nursing positions that are unfilled across our country and not a whole lot of prospects to come in and fill that. And so when you complicate this with the burnout factor, that number becomes staggering and overwhelming. And then our first responders, right? It's estimated that nearly 30% of our first responders suffer from behavioral health concerns, post-traumatic distress syndrome, anxiety, depression. These things are real out there on the front lines. And some of the situations that they walk into and some of, these situations where SDOH needs are not being met in our communities is just too much to take sometimes. And almost 60% of our physicians are thinking about leaving practice, and 35% of our nurses feel like resigning. We know the causes here, right? So this comes from AHRQ in regards to what we think that these causes are and what research shows us to be the causes. Obviously, that work-life balance, we've got family responsibilities in addition to the work that we do every day. And trying to find that balance is very hard, right? We're tied to work 24/7 now. And so how do you strike that balance? How do you get that? Not to mention the time pressures, right? So, healthcare is very focused on time. We've got to get things done. I remember many days being a frontline nursing staff and I had my 2:00 medication due and I knew I had 30 minutes before and 30 minutes after. And if I was outside of that, I was, in trouble. But what if my patient's coding in this room? And what if my patient's getting admitted over in this room? But I got to get that 2:00 med, right? These time pressures are real for our clinicians. It's a chaotic environment. Healthcare is often described as a VUCA environment, volatile, uncertain, chaotic, and ambiguous. That's the reality of every day for all of our clinicians. We've got low control of our pace, right? A lot of this is designed. It's all set up and we don't have control. It has control of us. And that, again, is a very hard feeling when you're a clinician. And then, of course, certainly a lot of the burnout and stress that we have comes from the tools that are supposed to help us, which is our electronic health record. But I would question if maybe we don't need to think about adding another one in here. And that's that impact of the patient SDOH issues and that lack of our clinicians being able to solve those for our patients. We talk about the quadruple aim, right? The quadruple aim, this changed from the triple aim in 2014. And it used to just be patient experience, population health, and reducing costs. But back in 2014, we realized that our clinicians are having problems in dealing with all of this. And so thankfully, we've now added the care team well-being as a point for our quadruple aim also, which is a really good thing. We need to have that focus. In the last few decades, let's go back over where our focus has been. And you can kind of begin to link how this is kind of maybe contributing to some of our problems today. Our focus has been on patient safety and achieving that zero harm, right? So when we have a patient that comes in and their nutrition status is so poor and now they get a bed sore, right? That translates into feelings for that clinician. What about patient quality? Kate talked a lot about our readmissions, right? We know that many people come back to the hospital because they're socially isolated or they don't have food to be able to sustain themselves for the next few days. We see that all the time coming in our emergency departments in order to get that level of treatment and care. Patient experience, right? We're to make it exceptional, right? That's really what we're supposed to be doing. We're here because we want to heal you. We want to keep you safe and we want to be nice to you. And again, with all of these different pressures, that becomes a little bit more challenging. And always that patient should be at the center of all of the decisions that we make. But how do you do that when you know you're sending that patient back home into an abusive situation because she's not quite ready to get that help yet, right? That's taxing emotionally on our caregivers. And then just we've spent a lot of time over the last several years really focusing on developing empathetic caregivers. And so we build them up to be empathetic, but then we don't give them the tools on the other side to be able to solve those issues that they're struggling with on a day-to-day basis. And these are all really good things. I'm not saying we shouldn't be doing these things. Obviously, these are all the right things. But what I'm suggesting is we need to take it a step further, and we need to talk about the SDOH and give our clinicians the tools that they need to be able to fix, to help at least mitigate some of that with our patients. You know, I go back to when Kate and her team started the food security, the insecurity screening. I can't tell you how many nurses reached out to me after we started that program and just said, thank you. I was able to send my patient home and I at least knew they had some food for the next couple of days until they could get connected with the right resources. And imagine if we hadn't put that resource in place, all of that emotional baggage that clinician would have had because of that. So let's talk a little bit about burnout, right? So we've got some definitions up here. It's just that combination of exhaustion, becoming cynical, that perceived inefficiency that now results in long-term job stress. Very, very difficult to get beyond burnout. A lot of times we see this occurring in people who are empathetic, primarily those people who are dedicated and committed to helping that patient. These are the people we want in healthcare. But again, we're causing some burnout issues because of not having all of the resources that we need for them. And again, some studies suggest that burnout impacts approximately half of all of our clinicians. So social workers, our therapists, our respiratory therapists. It's significant. And what's that impact? Well, we're seeing that translate by the clinicians using their feet to leave. Right? So RN turnover, it costs 1.2 to 1.3 times a nurse's salary to replace them. And for our physicians, it's even more. If you have a cardiothoracic surgeon that now is stepping aside because he doesn't want to practice anymore, or she doesn't want to practice anymore, right? That can be upwards of $1 million cost to that organization to replace that person. Would argue that giving them the resources, a food insecurity box, is much less expensive than replacing a cardiothoracic surgeon or a nurse. What about moral injury and moral distress? Boy, this has been, and we've been hearing a lot about this with the pandemic, but moral injury is that betrayal of what is right by someone who hold legitimate authority in high stakes situations. And then in regards to a statement made by our Ohio Nurses Association in 2020, it's the feeling that occurs when we are prevented from doing what we believe is right. We feel compromised in our ability to practice as moral agents according to our nursing code of ethics. And again, this is what we're seeing our clinicians deal with all the time. Moral distress, just a little bit of a slant when one knows the right thing to do, but institutional constraints make it nearly impossible to pursue the right course of action. Compassion fatigue. If you've picked up any newspaper or article or anything about the pandemic this year, you've seen this, right? You've seen the stories. You've seen the emotional distress on our clinicians' faces. And what this becomes to, this is the scary part, because our clinicians then become indifferent to those charitable feelings that they have, right? They can't practice empathy anymore. They just don't have it in them anymore to do. And that's really resulting in a lot of mental health issues and just well-being issues for our clinicians. And then probably even more concerning than all of this is the suicide rates that we see amongst our nursing staff, amongst our physicians, amongst all of our clinicians. We know, because the research tells us, that nurses and physicians have higher rates of suicide than our general population. Our female nurses generally go through pharmacological, which they obviously have access to with working in hospital settings or clinic settings. And then our male nurses, it's generally through firearms. Physicians, they have the highest suicide rate of any profession, and it's thought to be nearly twice of that of the general population. And then for our first responders. So in a recent survey of over 4,000 EMS team members, 37% of them had contemplated suicide, and 6.6% of them had actually attempted suicide. Those statistics are just really scary, guys. But there is good news, right? We've got the SDOH work that Kate and others are working on, and it's much more prevalent. And there are action items that we can take. So again, what we need to begin thinking about is that this isn't just a game to win, right? This is an infinite game, meaning it just continues and it just changes a little bit, but at the core of it, it's the same game. And so we've got to be a little bit stronger in this work. We've got to be more innovative in this work. We've got to think differently and outside of the box, meeting these needs. We've got to be a little bit more inspiring to our frontline clinicians and make sure that they know that the work that they're doing is purposeful and worthwhile. And we've got to rebuild some of that trust. You know, our pandemic has really had a lot of our clinicians questioning if they should be trusting the healthcare system anymore. You know, when they didn't have the basic needs to be able to go in and safely take care of patients in some areas, you know, that's a problem and that's concerning. So we've got some work to do around there. We can teach our clinicians to have these conversations, right? It's hard going in and asking somebody, are you being physically abused by your significant other? That's a hard conversation to have. We need to teach our clinicians how to go in and comfortably have those conversations, but we can't stop there. We need to make sure that we give them the resources and that we give them what those resources are. We have to teach them the resources and we have to give them access to them so that they can use them. And then we can begin to provide very proactive resiliency training, right? There's a lot of really good research coming out here about this. If you've not heard about mind-body training, I would suggest that you go out there. If you just Google it, you'll get right to it. Promedica, on our nursing side, we've begun onboarding all of our nursing with a Mind, Body, Strong training program. It's an 8-week course, 1 hour a week, that really focuses on health and well-being for both not only your mental well-being, but also your physical well-being. And so again, giving them those tools before they enter in that clinical force to be able to manage and navigate these situations. So here are some things that I think, from my perspective, needs to maybe happen. We really need to begin to research and quantify the impact of the patient SDOH on our clinicians. You know, when I was preparing for this and doing some literature searches, I couldn't find anything that really connected those concepts. I think it's a really good area where we have opportunity for research and how that's linked, right? We've got lots of research on moral distress and compassion fatigue, but we don't always connect all of the whys with that. And so it would be really good to have some data on that. Research to help find sound, evidence-based practices for our clinicians to assist them both personally for their own well-being, but also with our patients. And then just begin to open these discussions. We've got to start having these discussions across the board everywhere. And it can't continue where mental health is such a stigma. We've got to continue to break those walls down, and I think we're doing a really good job on that. And then we also would encourage you all to just practice wellness for your mind and your body. That's so important. And so I wouldn't be a good clinician, wellness clinician here, if I didn't take an opportunity to give you one tip, right? So block breathing. I don't know if you're familiar with this, but we're going to just practice it for just a minute here. So block breathing is where when you inhale, you just slowly count to 4. Then you're going to hold that breath for a count of 4. You're going to exhale for a count of 4, and then we're just going to hold for a count of 4. So this is a really great technique because you can use this anywhere. You can use this in a stressful meeting. You can use this in a stressful conversation with your spouse. Not that I've ever done that, but you can use this anywhere. And it's a very helpful tool. You'll be surprised at how much it does help you. So let's just go ahead. We're going to inhale. 2, 3, 4, hold. Exhale. Hold. Inhale. Hold. So if you just practice that a little bit, I promise you it'll be a great tool that you can at least use to help you get through that little bit of a situation. So again, I hope at least I've made you think a little bit about our clinicians and this impact that SDOH is having on our clinicians. I think it's a very different pathway when we have these conversations that we don't always connect with, but I think that we need to start doing that. So with that, I just want to thank you guys again for your time today. I hope this was helpful. Appreciate being here, and go UT Rockets.
Great. Thank you for those wonderful presentations. We're so delighted that you were able to share your morning with us. The next presenter I have the distinct honor of introducing, and that is Dr. Shetty. Dr. Shetty is the director of the Jack Ford Urban Affairs Center. She is also a professor here at the Department of Geography and Planning at the University of Toledo. She's worked as an architect and urban planner, concentrating on community-based planning, research, and evaluation projects, with a focus on old industrial cities that are experiencing deep population loss. And these cities are often called legacy cities. Some of Dr. Shetty's recent projects that are relevant to this symposium include the following. One is the evictions, and in particular, the high rate of eviction and challenges that they uniquely pose to individuals with mental health services. The other areas that she's been instrumental in working on have included water access and affordability. And her presentation today is on an analysis of poverty in Toledo and Lucas County. Please give a warm welcome to Dr. Shetty. Thank you.
Thank you, Dean Lewandowski, Dr. Walsh, and all of you for inviting me today. So to the audience that's watching, I hope that you'll find that there are lots of connections between what I'm going to talk about and what you just heard, even though we hadn't planned any of this ahead of time. So at the Jack Ford Urban Affairs Center, we consider ourselves a applied research unit on campus. And so what we're trying to do is do research and background work that supports the needs of community members and questions that institutions and individuals in the community might have or want answered. So I'm going to start with a very timely announcement that came from the CDC, or timely for our purposes today. So the CDC issued a press release on Thursday, and I will just highlight what they've said. Often unaddressed is the epidemic impacting public health in America, and that is racism. And then they make the connection between racism and different aspects of racism. So it's not just discrimination based on the color of one's skin or race or ethnicity, but structural barriers that impact racial and ethnic groups differentially. And they conclude by saying these social determinants of health have lifelong negative impacts on the mental and physical health of individuals in communities of color. So I'm going to use that as a starting point and talk about racism a little bit, the connection between racism and poverty, I'm then going to focus on Toledo as our unit of analysis and look at various dimensions of poverty within our city. As part of this work, we interviewed people who work with the poor in our city. So we'll talk a little bit about what people who are working with food access, housing access, health access had to say about poverty in our city. And I will, if we have time, talk about a couple of case studies. If not, I will skip that and then talk about the connection to health. So wealth, as we know, is unequally distributed by race. And this is particularly true when we compare white households to Black households in the United States. So a typical white family in America has 8 times the wealth of a typical Black family, 5 times the wealth of a typical Hispanic family. So we're seeing huge variations in wealth. Now, there are many reasons for this. So in general, a structure of a social structure in which racism is rampant. And then within this, we have, for example, in the area of home ownership and mortgage markets, we know that there is discrimination by race. And so if there are individuals belonging to a particular group who have lower access to good mortgages, they then have lower access to home ownership, and then they have lower access to all the benefits that accrue from home ownership. Similarly, if you look at the labor market, we see that our Black population in the US has access in general to jobs that require lower levels of education. These pay less, which means that they can accumulate fewer assets, which means they have less money to spend on food, housing, children's education, which means that the children also get jobs that are not very high paying and sort of start the cycle again. So I'll focus on a couple of aspects nationally and then focus on Toledo. So if you look at the graph on the left, this is looking at median wealth by age group and race and ethnicity. So along the y-axis is the percentage, and along the x-axis is the age group. So I want you to just pay attention to the 4 colors. From dark to light, they are white, Black, Hispanic, and other. And you can see that so I'm now talking about the graph on the left. You can see that the very first set of 4 bars, that is people under age 35, nobody has a lot of median wealth, but white individuals under the age of 35 have a little bit more than Black, a little bit more than Hispanic, a little bit more than other. By the time you get to the 35 to 54 age group, that you see that white individuals have substantially more median wealth than the other groups. And by the time you get to over 55, you can see how the gap has greatly increased between whites and everybody else. I should say too that other is a very catch-all category, and there is a lot of diversity within that group. But for the sake of expediency today, we will group them as other. On the right, you see inheritance by race, ethnicity, and access to funds. So inheritance is one of the big ways in which people have a head start in life. And so once again, divided by age group, you can see in the first group, divided by race, once again, darkest is white, next is Black, then is Hispanic, and then is other. So the first set of 4 columns is people who have received an inheritance, percent of people who have received an inheritance, so not very many. In the second set of 4 columns, people who are expecting an inheritance, also not very much at all. The third, but in each of these, you see that the first bar for the white population is higher than anybody else's. The third set of columns is the amount of inheritance that people are expecting. And you can see that it is substantially higher for white individuals than it is for others. And the last column, last set of columns that I found, oh, I have this, yes, so this. So the last set of columns is the percentage of people who have access to borrow $3,000 from a friend or family member in the event of an emergency. And it's 71% of white individuals said that they could borrow $3,000 at short notice. It was only 40% for Black individuals. So you can see that simply in terms of median wealth, inheritance, we are already seeing a huge disparity with respect to race. A couple more examples showing disparity by race. On the left, you see home ownership. So once again, Black, white, and other. So at each point, you can see that let me just, oops. Yes. So in home ownership by race and ethnicity, so this is a younger age group. As you go up at each level, at each stage in life, you can see that people are white individuals do much better than Black. This is the first three columns are white by age, Black by age, Hispanic by age, other by age. So if we just focus on Black and white, you can see that as people age, they have greater access to retirement income, retirement accounts, and then it drops. But you can see that it is higher at every age group for white individuals than it is for Black. So in terms of home ownership, median wealth, retirement account access, the ability to borrow money from friends and family, in every category, when we look at data nationally, Blacks do poorly. So there's a very strong relationship between race and poverty as well. So if we look at education, we talked earlier about this cycle of education and jobs. Students from low-income families are much more likely to drop out of school than students from high-income families. If you have low educational achievement, you know that your employment options are limited. And we also know that there's a very strong correlation between educational achievement and socioeconomic status. And so this then has very strong relationships with life expectancy that Kate talked about. And this is true across races. So if you have lower income, so if you're a Black individual, you have in general lower income and fewer assets than a white individual, your life chances then decrease over the course of your life. So very strong relationship between racism and poverty generally. What I'd like to do now is focus on Toledo and look at dimensions of poverty within Toledo. And I'd like to reiterate what Kate said earlier in her presentation, that when we're talking about poverty and racism, and as I get to social determinants of health, place is really important. Where you live is very, very influential in determining your life outcomes. So if we look at poverty, and I should say that I used 2019 data because the last publication was 2020, government publication was 2020, which reports on data until 2019. So I've tried to keep it consistent, and there are a couple of places where the data are so striking that I have picked up more recent data. So we'll see that in unemployment in particular. In the federal poverty level in 2019 was about $12,500 if you're an individual, about $25,000 if you're a family of four. So we were trying to look at within Toledo where people live who are below the poverty line. So the poverty line is pretty low. For a family of four to live on $25,000 is quite a challenge. So if you make $26,000, you are officially above the poverty line, but we know what a challenge that is. So this is a pattern that you will see repeating in many of our maps. So the highest poverty rates are in the neighborhoods right around the central business district. And this is quite severe poverty. So the darkest red signify that between 45 and 70% of the residents of these census tracts are living below the poverty line. So this is a very big challenge for those of us who are trying to figure out these issues in Toledo. If we look at education, and we talked about how education is related to poverty, 14% of Toledo's residents do not have a high school diploma, and for 32%, high school diploma was their highest level of education. So that is 46%, right? So 46% of our population has a high school degree or less. So this means that their job opportunities are limited to that pay grade, because as we know in general, as education goes up, income goes up, pay goes up. I would like to draw your attention to the last point on that list, which is that 70% of the jobs created in the city require only a high school diploma or a GED. So what we have is a population that understands that most of the jobs in the city only require a GED, a high school education. And so with a high school education, they're able to get jobs. The problem is that the jobs are not well paying. So when we come to a subsequent slide, you will see that our unemployment rate is not terrible. We're right about where the country and the state are, but it's still not a very good situation, because even if people are employed, because their education levels are low, their employment, the income from employment is low as well. Let's look at housing. So one of the most established ways of developing assets and being able to pass on an inheritance to your children and future generations is through home ownership. But home ownership in Toledo is fairly low. So we now have almost 50% of our city are renters, and just over 50% of our city are homeowners. The other challenge is that these homes are not, in general, not very expensive. So the median cost of the house, of the average house in Toledo, is not very high. So even when people are building assets by owning a home, the home itself is not very valuable. And some of it is because our housing stock in Toledo is quite old. The Housing and Urban Development Department has a rule of thumb, and this is a widely used rule of thumb, that in general, a household should not be spending more than 30% of its income on housing. And so as people become very wealthy, it doesn't matter as much, but especially for low and middle income people, 30% is considered about as much as a household should be paying. But we found that 45% of Toledo's renters are paying more than 30% of their income on housing. And a fifth of Toledo's homeowners, even with mortgage rates as low as they are spending more than 30% of their income on housing. So this means that both for renters and homeowners, their incomes are pretty low, because even if their rents and mortgages are not very high compared to, say, Columbus or New York or Miami or San Francisco, even if they're not paying a lot in mortgage or rent, it is a substantial proportion of their income, which doesn't leave a lot of money for other things. You can see that with disability and public assistance as well. So public assistance, we focused on food stamps use. They are for the census tracts that are closest to downtown, right around here, the dark red, are the ones that have the highest percentage of residents who are on public assistance. With unemployment, once again, you see that pockets of higher employment, darker colors are closer to the center of the city. This is where I wanted to point out that we have recent information. And in February 2021, our unemployment level was 6.3%, which doesn't sound too bad. But we know that even when people are employed, they don't make a lot of money. And we know that in April 2020, so we've recovered now, but last year, about a year ago, the unemployment level in Toledo was 21%. And it was so shocking that I put it in as a little aside. We looked at two dimensions of cost of living to see how expensive it is to live in Toledo. So by one calculation, so this is what the cost of living is, what the minimum wage is. So the federal minimum wage is $7.25. In Ohio, it's $8.70. The median household income in Toledo is $18.80. So if you look at, by one calculation, the minimal amounts that one adult would need to spend in Lucas County, so this is not Toledo, this is Lucas County, you would need about $1,500. This is not counting cable, not counting internet, not counting savings, etc. You would need about $1,500 a month to live. But it is just possible for a single person on the federal minimum wage to live with the Ohio minimum wage to make a living, to just scratch together a living in Lucas County. So if someone was making the federal minimum wage, it would not be possible. They would go into debt. One adult with just one child would need about $19 an hour, but we know that our minimum wage is about $8 an hour. So this is an unsustainable minimum wage, which means most of our minimum wage residents are struggling. We have another calculator, this one based in MIT, which says that one adult in Toledo, now not Lucas County, needs $10 an hour. One adult with one child needs $22 an hour just to make ends meet. But we know that they're making around 8 plus. When we talk to people who work with the low-income population in Toledo, we had a few ideas that they shared that we thought were important. One is we used to have a very robust environment of community development corporations that were neighborhood-based, that worked with residents who were low income or poor or unemployed or needed help in different ways, whether it was health or housing or with business ownership. Those CDCs have now disappeared. So that very strong infrastructure of support is completely gone. They said that our current system is very siloed. So you would go to one place for healthcare, one place for housing assistance, one place for mental health services. And one of the most interesting things they said is that poverty needs to be understood. This was one of our interviewees, as an issue with 1,000 cracks that need to be filled. and that poverty limits a person's freedom of choice to live an abundant life. So it's poverty not just in terms of money, but it's poverty in terms of freedom, because you don't have as many choices if you are a poor person. And that as a city, we need to focus much more on organization and management, and to make sure that we have equitable distribution of funds. So I'd like to end by saying that there are many aspects of health that are also more prevalent among the poor. So certainly aspects of physical health, which are related to exposure to toxic substances. So Toledo has dealt with the issue of lead, with pollution, with poor nutrition that Kate talked about. We know that children have hormones that suggest higher stress levels, and that these are associated with poverty. So poor children, and particularly poor Black children, have higher levels of measurable stress than other groups of children. We know that mental health and substance abuse issues are overrepresented in low-income populations. So we know that poverty affects people in multiple ways, and health is one of them. So I'll end there, and maybe we can, I'm right at the end of my time, we can do questions later. All right, thanks.
Thank you, Dr. Shetty, for that wonderful talk, and very informative in terms of income levels which affect all of us here in Toledo and Lucas County, where we live and reside.
I have the pleasure this afternoon of introducing our panel. I'm going to start off, though, with just a little bit of introduction to make sure that we're all on the same page. You've been hearing all about social determinants of health, and I just want to make sure we're all, for sure, the vast number of things that are encompassed under this umbrella. Can I do the slides? Oh, yeah. So first of all, you've seen this definition on some slides embedded previously, but to just look at the definition of social determinants of health are conditions in the environments in which people are born, live, learn, work, play, worship, and age that affect a wide range of health functioning and quality of life outcomes and risks. The WHO adds a bit more dimension that money, power, and resources at the global, national, and local levels shape these conditions, and that SDOH significantly impact health inequities. In Healthy People 2020, there were first depicted these 5 determinant areas of social determinants. And I use the slide because it has a little bit of additional detail of the kind of things that are encompassed under these 5 determinant areas of economic stability, education, social and community context, health and healthcare, and neighborhood and built environments. So you can see that a wide range of issues are encompassed when we talk about social determinants of health. Now we have Healthy People 2030, and the social determinants of health still play a very important role. They've added a little bit more description. So now the focus is not just on education, but on educational access and quality, healthcare access and quality, economic stability, social and community contexts, and neighborhood and built environments. Healthy People 2030 recognizes an increased and overarching focus of social determinants of health. We've always known it's important, but the importance of these factors are even increasingly recognized in our 2030 document. Recognizing that social determinants have a major impact on people's health, well-being, quality of life, and also contribute, as you've heard in some of the presentations already today, to the wide health disparities and inequities. And one of 2030's 5 overarching goals is actually specifically related to SDOH: create social, physical, and economic environments that promote attaining the full potential for health and well-being for all. This is just a list, again, in some detail that you can kind of look at, that identify some of the various factors that go into the concept that we kind of just umbrella under SDOH. Again, I just want to show this slide very quickly. Kate Summerfield showed this slide that talks about what determines health. You know, I think we know genetics and medical care are certainly important, but we can look at 60% of what determines health are environment, social factors, and patient choices. Patient choices have to be remembered and viewed in the context of choices that people are able to make. So Dr. Shetty really talked about under poverty, you can't make the same choices that somebody else makes who has a lot of resources. And so I think that even looking at patient choice, it's not all individual, you know, if they just pulled up, you know, by their bootstraps and, you know, made better choices, they would be healthy. It's not that simple. We know that a lot of factors go into choices. So I just wanted to give that context as we enter into a really exciting panel discussion this afternoon. And I'm going to start out introducing all three panelists, and then we're going to let them talk, and then we're going to have a question and answer session. So if you want to write some questions in the chat, we'll get them processed and get them here for people to talk to and answer. So first is Dr. Marianne Churchwell. Dr. Churchwell is an associate professor in primary pharmacy practice in the College of Pharmacy and Pharmaceutical Sciences here at the University of Toledo. She completed her PharmD at Wayne State University in Detroit and her pharmacy residency at Detroit Receiving Hospital. After that, she did a fellowship in critical care nephrology at the University of Michigan. She joined U Toledo in 2005 and has a full teaching schedule and is a very active faculty member and a member of our Social Determinants Task Force. She's a board-certified pharmacotherapy specialist and a fellow of the American College of Clinical Pharmacy. She's been an active publisher and is an active member of the American College of Clinical Pharmacy, serving as a reviewer, and also an active member in a variety of other capacities in that organization. And she's a member of the Council of Faculty's Curriculum Work Group. Dr. Raymond Whitty, Dean Whitty, is currently Dean of the Judith Herb College of Education at the University of Toledo. He provides mental health information sessions to various groups, including student teachers, in his capacity of being a licensed school psychologist within the state of Ohio. He's also a mental health first aid instructor. He worked in a variety of places in schools and clinically, and his professional training and collegiate instruction has focused on individual and system assessment and intervention, along with mental health provision in schools. He's an active writer. He's written 3 textbooks, a slew of articles and book chapters, and is known for mental health aspects in education, K-12 education. He's also been a consultant and has focused on systemic assessment of diversity practices for medical and mental health professionals. Dr. Heather Sloan is Associate Professor in the Bachelor of Social Work program in our College of Health and Human Services here at the University of Toledo. She received her Bachelor of Science from William & Mary and Master of Social Work from Virginia Commonwealth University, where she specialized in healthcare social work. She completed internships working with the homeless in Richmond, Virginia, and in the surgical trauma intensive care unit there. As a former healthcare social worker in intensive care and rehabilitation, Dr. Sloan is a long-term member of the Interprofessional Faculty Steering Committee, investigates the culture of professional education and interdisciplinary collaboration through the lens of decreasing medical error and health disparities caused by implicit bias. She has focused her research on understanding poverty and the importance of empathy to cultural humility. Dr. Sloan is also an active member of our UT Social Determinants of Health Task Force. I'm excited to have these three colleagues here today, and I'm going to start with Dr. Churchwell and let her talk about some of the work we've been doing.
Good morning. Thank you, Dean Lewandowski, for those nice introductions for all of our speakers for this panel session. And so I'm here today just to bring you an update about what our working group has been doing and just to sort of do a quick overview of that. But thank you again and good morning. So I'm happy to here this morning to bring you some information about what our working group is working on. And we've been working on this well over a year. We were tasked by Dean Lewandowski. She charged us with developing an SDOH module, sort of a SDOH 101 module for students to learn, so students would have generally a common knowledge, a basic understanding, make sure everybody's sort of on that same page, that same footprint with understanding the important factors that go into social determinants of health. And in doing that, we were tasked with having our first major deliverable for fall of 2020. And that was for the Interprofessional Education course, or the IPE course. And if you're not familiar with this course, it's a course that has students from at least 10 different disciplines, and to bring them together to learn more about each different profession, and using that knowledge of what each other's strengths are in improving patient care, they use that to solve problems. And so that this is a multidisciplinary approach to solving problems and improving patient care. So how do we start? Well, first, we had some initial members of the team, the group, but we needed to assemble a team from different colleges and with different disciplines, different backgrounds and experiences. So, and in doing so, I want to start out formally by introducing the team. And our team is comprised of our working group of Michelle Masterson, Dr. Shipper Singh. Tara Cowell is our graduate assistant with a background in education. Suzanne Lee from the Dean's Office in the College of Pharmacy and Pharmaceutical Sciences. Heather Sloan from social work, who will be speaking in a little bit. Monica Halliday Goodman, myself, and of course our leader, Dean Lewandowski. I had to put that in there. Our representative colleges, I wanted to, I like to surprise her. The School of Interprofessional Education, the College of Nursing, College of Pharmaceutical and Pharmacy and Pharmaceutical Sciences, College of Human Health and Human Services, and College of Medicine and Life Sciences were all represented. So where do we start? We had to develop this module. So we started looking at, literature that's available, online modules, courses at UT. We talked to our team members. Did they have lecture material, cases, activities? And a lot of what we looked at and saw was higher level. It wasn't basic. It wasn't going to bring everybody to have that same footprint, that same understanding of SDOH that we were looking for. So we're educators. We needed to take a step back from this and take a look at, what do we really want to do? So we should know better. We needed to put together some learning objectives, and that's where we started. So, and this was great to have this because it always brought us back to what is our real goal to get this done. So our learning objectives were to define the social determinants of health and their domains, describe the impact of SDOH on health outcomes, apply concepts learned within the module to case study examples. So fairly simple, but it really kept us on track throughout this process. We were very fortunate that team members did have some lecture material. They had ideas about cases, about maybe some videos that were available, freely available to use, to embed into this module. And so we took a lot of our information from Healthy People 2020, looked at SDOH domains and those key issues within those SDOH domains. So we went back and we brought in this material. We brought in a review for students of the 5 SDOH areas. We developed a narrated module with slides, videos that were embedded. We were able to break up the video into different segments so we could have the students sort of look back at what they were seeing in the videos and answer some questions afterward. So with scenarios as well, cases, and of course, we have to have a quiz at the end, as students were required to complete the online module prior to the first IPE activity. And then students were supposed to actually take this quiz afterwards. We'll talk about that in a minute. The SDOH domains, this is just an example of what one of the slides looked like that we had in the module, including the SDOH domains and key issues. So initial impressions. The work group felt the course content was good. We felt that the video clips in the cases highlighted and reinforced concepts. The students, they felt it was good. You know, they felt it was good material. You know, some had some of this information prior. They knew a little bit about this, and others it was new material. But many students took the quiz before they watched the module. Not what we had intended. And so looking back at some of this, now we have, delivered this one time. We do have some work to do for fall 2021. So what's our plan for fall 2021? Well, we need to update the information using Healthy People 2020. We need to review, see if there's anything else out there with available programs to sort of spark our creative spirits to get this together. Look for information again, that may be out there to update for SDOH. Work with a UT instructional designer is what we had planned for 2020, but we didn't have a big timeline to be able to get this done and ready for an instructional designer to help us. But we're already starting that process now for the fall of 2021. We want to improve the flow, embed the questions within the module, not take a quiz at the end. We still might have some sort of summary questions at the end, but we really just want to have the students do more of an interactive and embed that. And so for the fall 2021 course, and depending on how the bigger task force views these materials, we'll hope to disperse this to other programs at UT that are interested in this information. So thank you so much for inviting me and allowing me to share a little bit of information about what the SDOH work group has been doing. And we look forward to sharing any updates in 2022. And again, our task force. Thank you.
Thanks, Dr. Churchwell. I think it's really exciting sometimes to figure out what do all these task forces in the university do anyway. And I think this is one of a variety of projects that our SDOH task force is working on at the university. And I really appreciate all of the leadership that Dr. Churchwell and the whole group have given to this process. Now we're going to move to Dean Whitty, who's going to talk about one of the other aspects of social determinants, and that's the social determinant related to education. Dean Whitty.
Good morning. Thank you for having me, Linda. It's a pleasure. So obviously you've heard just some amazing information from individuals, and I would just like to provide a very brief review of kind of the impact that education has in regards to social determinants of health. So if I do this right, there we go. As you've probably seen, this is a common slide that you will be presented with in numerous presentations regarding social determinants of health. I just want to highlight the fact that education is obviously there, and it's really kind of the whole gambit if you take a look at that. What's listed, of course, is literacy, language, early childhood education, vocational training, and higher education. If you think about it, it is literally the lifespan. And those are very important areas that obviously need to be attended to if we are really going to move this forward. Literacy and language go hand in hand. And obviously that is usually embedded in the early childhood programs, Head Start, other preschool daycare offerings and so forth. And then that obviously moves all the way along as the student goes through the educational process to opportunities that hopefully will allow them to be very successful members of society. That could involve vocational training and or involve higher education. So those are all elements that have to be attended to and recognized as part of this. I've just provided a short, actually borrowed from let's see, that's the American Public Health Association. And these are just kind of telling statements. This has been reiterated already, that education and health are linked. The better the educational environment, the more opportunities, the greater the likelihood of individuals really experiencing a much higher quality of life. And these just kind of factoids really attest to the fact that those are indeed extremely important. Now, wonderful quote from Dr. Anton, single most important modifiable social determinant is education. We can make all the difference. And I think that's where a real focus really needs to be in order to make and move this dial if we really intend for that to happen. Income and education are directly related and connected to each other. And of course, they are the strongest correlated items to that. So once again, and has been mentioned before, these are modifiable. These are and can change. We can improve these conditions. We can enhance the educational experience and correspondingly enhance the lives of young people. So, real quickly, more educated you are, the more likely you will probably live, the more money you will likely probably have, and hopefully a higher quality of life you will experience. Once again, this all starts early. And, you know, there was a time in my day and time where kindergarten was where you started. Actually, fact be known, I never went to kindergarten because it wasn't available. So we have really changed and recognized how important early childhood education is. But it's not available to everyone, unfortunately, as listed in the next bullet. Unfortunately, only about 40% of eligible preschoolers take advantage of Head Start. And I was fortunate enough to have Dr. Grant in a social professional event for the college. And, excuse me, he made a very telling statement. He indicated that over 82% of Toledo's kindergartners are not at the level of kindergarten readiness. Now, there's a lot of reasons for that. Obviously, access to high quality education is paramount here. To be fair, over the time of my tenure in education, there has been a shift in the sense of from a developmental perspective to more of an academic readiness aspect to the earlier grades. So kindergarten had more of a first grade expectation in regards to academics, and that has subsequently moved down. But I think the real message here is that we need to have good quality educational experiences, and that includes academic and social emotional education experiences for our young people. It's an investment. These are individuals who are going to really substantiate what we can do and how we can grow, whether it's Toledo, the state of Ohio, or the United States, or internationally. So that's, I think, the message there that hopefully everyone could take away. Not surprisingly, the ongoing challenge is to keep students throughout their educational career. We obviously have differential graduation rates. Thankfully, it's relatively high at 85%, but when you start kind of dissecting that a little bit, obviously the rates vary depending on the groups and opportunities that are afforded to them. as indicated by Dr. Wright's comment, I think it's very telling in the sense that unfortunately minority groups are in most cases disadvantaged because of other contributing factors that can influence the educational progress of those students. All those listed above can certainly accentuate already potentially existing disparities. Many of you probably are aware that unfortunately research is very telling in the sense of the disproportionality that exists in the sense of higher expulsion and suspension rates for minority boys, feeding the famous highway from schools to prison aspect. Unfortunately, that is still the reality. Also, students are most likely to get suspended and expelled from traumatized backgrounds or situations and events. Now, I don't want to paint a complete gloom and doom picture here because that is not the case. California in particular has made some astounding work, especially as they have utilized what's referred to as trauma-enforced practices in regards to understanding why students act out, how they can be assisted, and not surprisingly, or perhaps pleasantly surprisingly, is the fact that when these practices are involved with our students, there are other potential benefits, i.e. even higher instances of test performances, which by in itself is obviously an important aspect. So we can make progress. It's how we choose to do it and how we educate our educators and all of our professionals to assist students wherever they're at. This is, I think, a nice image that gives you the complexity surrounding mental health related issues, especially for individuals who are basically kind of out of that cycle of being able to access mental health services. I don't have to tell you that because of that, there is unfortunately a potential for mental illness and prolonged chronic kind of mental health issues. So if you kind of go through all the interactions that you're looking at there, clearly the one, or actually there are several that probably jump out. What I've found personally in the work that I've done is that it's not a case that families and students don't want help. They can't find it. They can't get providers or practitioners. The clinics are full, or they have to be put on waiting lists. So that's obviously an important aspect. You have to have the services available. You have to have a way to do this. Now, because of the pandemic, we have learned to do everything seemingly virtually. I would assume and would hope that a new era and access to probably mental health is coming along. Now, with that said, we have to have access through the internet. We have to have computers. We have to have all that as well. I don't think it'll ever replace face-to-face. I'm biased as a licensed psychologist, but I do think it fits an important need. And just having someone that you can reach out to and connect with makes a difference. It's made a big difference this year. It would be the same for obviously any time, especially for students who are going through either challenging issues or, quite honestly, educators who are trying to deal with the complexity, just like the nurses who were identified earlier today. I teach my students, I tell anyone who will listen, physical and mental health are flip sides of the same coin. You have to think of it that way. They both interact, they influence each other, and unfortunately, we've paid less attention to the mental health end. We understand the physical health aspect. I think all of us usually get that. Now, my generation, and I'm just speaking for myself, mental health was not a discussed item. It was something that was never a part of the conversation. In fact, you were never even to admit that you had any concerns about mental health. I'm happy to report that my students and younger generations understand that this is an important aspect and they are courageous enough to have the conversation. Good for them. They need to continue to do that. Given the impact of obviously the pandemic, Collective mental health agenda really could never be more important than today. And I think it will continue. Even once we get out of the pandemic, I think it's still going to be a primary issue that we really have to continue to focus on and put our resources together to really provide a comprehensive support system. Finally, I was asked to speak just briefly about the impact on disability. And the statistics are probably quite telling as well. Depending on what report you look at, I obviously pulled the Americans with Disability Household Economic Studies report, but roughly speaking, at least 56.7 million or more adults can be identified with having a disability that impacts the quality of their life. That's important because unfortunately, as a collective group, those individuals as a group tend to be poorer, less educated, and less likely to be employed. Once again, limiting access and resources to individuals who desperately may need them. Of course, the need for support services is critical for everybody, but especially those with limited financial resources and access to those resources. Once again, as was mentioned before, quality of services, access of services. Those are two elements that have to be there for everybody. And that's it. Thank you for your time.
Thank you, Dean Whitty. That's really a lot of information for us to digest, really, and how important education is as a social determinant and the factors affecting education and outcome. Our next panelist is going to be addressing another important area. We've talked about a lot of the issues, but questions about, well, what do we do about it, certainly come into our mind. Dr. Sloan from Social Work is going to talk about an exciting program that she's been implementing in the community and is addressing important areas of social determinants. So Dr. Sloan.
Okay, well, I want to start off by thanking you guys for inviting me to talk about how I'm learning with my students about social determinants of health in the community of Toledo and thinking about creative ways to teach about social determinants of health. So first of all, I want to say most of the pictures that are in the slideshow are from artists who were inspired by the Writers and Fearless Writers, which is the program I'm going to be telling you about, either from exhibits, presentations that we've done as a group, or things that they've published. This is already said, but I just want to say, before I went back to get my PhD, I was a healthcare social worker, mostly in ICUs. The last part of my career was in perinatal medicine, so I worked with high-risk pregnancy and neonatal intensive care units. So I've been a part of IPE for a while, interprofessional education. When I went back to get my PhD, and I'll go through some of these slides here. When I went back to get my PhD, it was in cultural studies, and I actually looked at the culture of medical education, particularly understandings of poverty. So as part of my dissertation research, I interviewed 24 physicians all over the country and asked questions about poverty. I'd say the majority of the physicians I talked to held from some pretty basic stereotypes about poverty, things that thinking poverty was the result of individual decisions or laziness, things that we think of as stereotypes. So it really unearthed some implicit bias about poverty. But there was a handful of physicians that really had a nice, complex understanding of poverty. And so I looked really carefully at their lived experience, their education experience, to see sort of what was the catalyst for them to really have a more sort of accurate view of poverty in the United States. And a lot of that was actual experiences that countered the stereotypes. So sometimes it could have been just one experience that countered the stereotype where they had a more empathetic view towards poverty. So I really wanted to create an experience early on in this is a quote from my dissertation from a physician talking about really feeling like he had no preparation for
what the concerns for people who had economic disadvantage until he was exposed to the community that he was working in. So I really wanted to come up with a way to create those epiphanal moments for my students as social workers and for my interprofessional students. And I have been introduced to Amherst writers and artists through, as a healthcare social worker, actually a facilitator who created writing groups for individuals with cancer. And I found it fascinating. I felt like it was really a social justice intervention because it focused on strengths. So you were giving strengths-based feedback. There was a leveling of power. So everyone was writing, everyone was sharing. And that it really forced you to listen carefully and learn from each other. So I wanted to use it as a place that could potentially create epiphanies for students. So to give you an idea, so Fearless Writers is the program that I developed here in Toledo. It's a mix of IPE students or interprofessional students from the university. This year we have a nursing student, several medical students, physical therapy students, and social work students that write with high school students. So we started at Rogers High School and we've been expanding to other high schools in the area. COVID has actually helped with that because we're bringing them in virtually as opposed to having to go to each individual school. And so what we do is we write into prompts and they write for 5 to 7 minutes. We all share and give feedback to each other. So it creates a connection in an interesting way. So originally my purpose was to just have people be better advocates for themselves, the high school students, and for our interprofessional students to have that epiphany that might create advocacy and change medicine. So one of the other things I found about the doctors that really had a complex understanding of poverty is they were actively doing things in their practice to try to get at disparities. So if that was finding out about medications that be less expensive or actively advocating within their professional organization. So I wanted to create that kind of advocacy in our interprofessional students here at University of Toledo. Okay. So you're missing all this great artwork because I'm nervously going through this. So after we did a pilot at Rogers, just as a writing group, I talked to the teachers about maybe involving the kids in research, participatory action research. So if you aren't familiar with PAR, it's really the community is a part of every aspect. What do we want to research? How do we collect the data? Presenting and publishing the research together. So we used a sort of auto-eth version with the little bits of writing or even poetry-informed research around social injustices that the kids were upset about or wanted to learn more about, and the college students too. So it's a collaboration of, what should we spend time on? The first thing we really looked at was social separation, neighborhood segregation. That's really a big part of the United States. So redlining, if you're not familiar with the policies of the 30s and 40s, where parts of the city were sort of redlined for okay to be houses sold to African-American families. And over time, these redlined areas in many cities, including Toledo, continue to have difficulty economically. So some of those decisions that were made systemically continued to come in the way for all of us, actually. So the next topic that the students wanted to write about was gun violence, and we had noticed that the kids wrote about guns, their fear of guns, people they loved who had been injured by guns or even murdered. And so it was a very present conversation. So we took that on, and I have samples of what the writing looks like so you guys can know. So Javon Johnson was the senior, and he wrote this after there had been a shooting at a football game. He's a football player at Rogers High School. And it's titled, "It Was Cold. It was cold. The whistle blew from the next play to start. Both teams are lining up. Bang, bang. Players on the field began to run. The band is still playing. Cheerleaders looking confused. What's going on? Bang, bang. Everybody's running. Police sirens going off. Bang, bang. Kids crying. Moms calling for their kids. People lying on the cold, wet ground. Some escaping into the school where it's safe. People crowding. Players crying. Moms angry. Siblings calling out for other siblings. Bang, bang. Whoop, whoop." This piece was written by a mentor who's a social worker, grad student, about the same incident. Flashbulb. It's like time freezes. Everything still clatters at full trot, but your brain's going that much faster. You see it all at once. They call them flashbulb memories. Sometimes so intense that you remember everything in perfect clarity, like it was a picture taken. That's why trauma hurts as bad as it does. It sticks with you. All the horrible details splayed out across your mind, creeping into your subconscious. And it sticks there, maybe forever. Our minds are a tapestry of these moments, some beautiful and some horrid. And I don't know what to do about that. These memories make our minds, and our minds make ourselves. But there comes a point where taking the bad with the good becomes unbearable. I don't blame the suicidal. They know things I don't. They've seen things and they know. So currently, we've been working on prompts that are inspired by the history of Black communities here in Toledo. So we've looked at artists and advocates and writers, both from Toledo, but also that have influence. So like from the Harlem Renaissance or the Black Arts Movement or the Black Power movements, including the Black Panthers and their involvement here in Toledo. So when I look at the social determinants of health and try to learn from my experience in Fearless Writers, what I notice is that a lot of the social determinants really can only be shifted through advocacy. So me building advocates, or us building advocates together, is what goes after many of the domains that you guys have been seeing in the slides leading up to this. But also, we have some control over culture and attitude shift. And so that's also where I focus my time, like how do we shift some of these things? And so I spend a lot of time looking at the social and community context of social determinants of health, in particular civic participation and discrimination. So civic participation, meaning you do have a voice, even in a neighborhood where it sounds like you don't, or you've been told you don't. And so we'll stand beside you as you build that voice and you present to academics, or you get published and become important like you deserve to be. So sharing that privilege, sharing the academic privilege with high school kids in Toledo. And in terms of discrimination, just really looking closely at what creates discrimination. And for me, looking at the pedagogy, cultural humility is something I gravitate towards. This idea that I'm not the expert on people's culture, they're the expert. They get to tell me what this means to them, and I don't get to put that on top of them. But also looking at anti-racist and inclusive pedagogies, and being really encouraged to see that interdisciplinary and interprofessional education are seen as crucial to that, in part because if I can't respect my team and I'm not open to different perspectives, there's no way in heck I'm going to be able to do that for my patient or their family or the community. So it's building those muscles on a team. I think it's also really important for the sciences and social sciences to reach out to the humanities and the arts, because they study discrimination. They're often bringing us lived experience of discrimination that we can learn from as social scientists and scientists. So the two main things I play with, and I'm not doing the slides, so I feel bad you guys aren't seeing any of this. The two main things that I spend a lot of time thinking about are implicit bias, and breaking that down into learning about white fragility or even privileged fragility, microaggressions, stereotype threat, intersectionality, code switching. Hopefully these are terms you've heard about. But talking about this with students at Rogers, and also bringing them into the classroom, the IPE classroom, as well as the social work classroom. And also rethinking empathy. So empathy from sort of a medical standpoint has sort of been taught as a detached thing, where you have to hold yourself protected, or it would somehow create bias or weirdness or that would harm the patient or even the practitioner. And I, along with a lot of anti-racist people within education, are talking about an embodied empathy, learning how to connect with your patient or your client from a sensory level, which is often can't happen without understanding the story or listening carefully, which I think that the arts and the humanities are very helpful in sort of filling in what does that lived experience look like. And that's all I have for you guys.
Thank you for that really important example of addressing some of these issues. This is really powerful work that you're doing. And thank you for sharing that. Now I have some of the questions that you've been sending in during the course of this workshop. And Dr. Sloan, since we were just talking about your area, I have a couple questions for you. One is, do students do writing as a part of normal high school class time, or is this like something added extra that they have to do?
So at Rogers High School, we're a part of the AVID program, which is which is sort of a program created to support students who might need extra support. So we were actually brought in to be a part of time where they had tutoring or open study to do the programming. The other high schools we're a part of were really more within breaks during school or after school that they come and join us. We have a weekend time too, where we try to bring the different high schools together so that there's it's disrupting social separation even at the high school level. So BG High School, early college, Toledo Tech and Rogers have been our main participants. And so kids that would normally get to meet each other are getting to meet and write together.
Great, thank you. Another question about education, Dean Whitty, what types of strategies can Toledo use to foster education in our Toledo public schools?
Well, right off the top of my head, I would say there are a lot of little things that add up to a big thing. First of all, positive PR. Just letting know, educators are important. Elevating that professional status. Obviously, that can happen in a number of different ways. Most think of salary, but status goes a long way. So the purpose, value, and support aspects. You can sometimes see on the TV programs or the local news, recognizing local educators, finding ways to support our schools, the heroes work here kind of notion. And I would say really getting involved with schools, become active, attend Board of Education meetings, share your ideas, your voice, all those things that you would do hopefully when you're passionate about something. We would love to have the passion for education. And I think that would be a really big step forward.
Thank you. So it's a real different dynamic having a panel kind of socially distanced through the room. So, we're going with the times though, and we really appreciate them hanging in with us. Another question is, does Toledo have neighborhood health centers? They certainly do. I mean, downtown neighborhood health center is a very big one. Dr. Churchwell, do you want to talk a little bit about a couple neighborhood health centers that Toledo's been involved in?
Yes, there's a couple of them run out of Cedar Creek Church, which are medical students, pharmacy, nursing, social work, and several other disciplines as well. All participate in a free clinic, and usually it's run on Thursday evenings, and donations, and we have fundraisers throughout the year for it as well. But it's a great way that our students give back to the community and also, interact with our community members. There's also a mobile clinic that is staffed also that students participate in and help out with the care of individuals in the community, and that's the Labyrinth Clinic. And I believe they've opened one up temporarily in Tabernacle Church as well.
Great, thank you. One question I think may have been from our keynoters who had to leave is there mandatory therapy supplied for hospital workers? There certainly is increasingly a focus on having appropriate mental health kind of services for healthcare workers, particularly with all of the statistics that Dr. Sievert was talking about. Not mandatory usually, though. I mean, we need to have, free choice in going into therapy unless there's some court-ordered situation or something. But, for hospital healthcare workers, I think it's becoming increasingly recognized the need for that. And we need to get better at having programs that are accessible to everyone, though. Dr. Sloan, if I can go back to you, here's another question. Shifting culture is a monumental task, even in an organization. What have you learned about how to do this in a community?
I think for us at Fearless Writers as a project, just really taking opportunities to create audience for what the kids have to say. I think also having hard conversations, being a part of some of the forums that have been going on because of a lot of what's been going on with Black Lives Matter. I think just being open to conversations, being open to being a little uncomfortable, and really looking closely at sort of the fragility response to some of these conversations. But I think just taking every opportunity, having your ear open to where there's open discussion and being a part of that. I think you can have a big influence on some of that shift. I think we think it's daunting. It's more daunting than it actually physically ends up being.
Dean Whitty, I passed one of the cards on to you. It's kind of a long question. Do you want to just go ahead and read the question and, give some thoughts on that perspective?
I'll do my best.
Topic.
The question basically is, do you feel that the use of non-uniformed police officers with awareness of mental illness and other toxic stress conditions help the setting of a school system instead of a trained officer that is taught to de-escalate a situation with forced violence if needed? Well, obviously, this is a very detailed question, and I am not, I don't think, qualified to talk about where police officers fit, so to speak. However, with my dealings, I am aware of actual training that police officers now receive to make them as open to having conversations with students as possible. I clearly understand that wearing a uniform creates a very different visual impression, especially for young people. But I think, quite honestly, everyone in a school building is really, in a sense, responsible for maintaining the general well-being of that school. And I think everyone can benefit from kind of having that awareness, paying attention, and when you see something, reporting it, especially if you're just concerned about how that person is acting. Sometimes I get questions about, bystander effect and when should I say something? And the answer always is, if you suspect something's going on or someone's in a situation where they really need help, then I think you need to do just that and let individuals know that that's a situation that needs to be dealt with. So,
thank you. It's an important topic too. Dr. Churchill, what's your next step after this SDOH module? Will it be disseminated to all UT students? That's our hope, but I'll let you talk about that.
Yes. Well, that was our hope last year as well. But we really just, we needed to get some decent information and we don't have the module exactly where we would sort of like it as an interactive, as we would like it to be. So we're hoping to get it into a program that makes it easier for individuals to sort of go back and forth throughout the module and looking at different things at their own speed instead of having sort of this paced PowerPoint presentation. So once we get it in that format, I think it will be better for everybody.
Thank you. We're also looking at possible collaboration with Promedica in terms of how they might incorporate our module in terms of some of their orientation or how we might share some of their material. So we're very fortunate to have the partnership that we have with Promedica Health, which is such a leader, as we know, in this whole area. I think we have time for one last question, and Dr. Whitty, it's for you. Do schools need more programs on meditation time in the morning to decompress, to separate learning from home or facilitate learning from home? I guess it's a mental health in schools question for you.
It is. Personally speaking, I think there's a lot of ways we can integrate just good mental health practices throughout the entire school day. If you think about it, school is a series of transitions. Students get off the bus, they go into the building, they go into rooms, they may stay in that room for a while, then go to someplace else, go to the cafeteria, etc. So because transitions are just part of what happens, I think it's very smart to have things that allow those transitions to go as well as possible. And that's where I think we're striving to really produce the best teachers we can in the sense of reading and math and writing and so forth. But as well, I think we need to produce teachers who are really kind of wellness oriented and address the kind of interpersonal dynamics that go on for the learners that they teach. So yes, I think there are a lot of different things that could be used to help students just feel more relaxed, more centered, especially as they move from one activity to another. And what's really quite exciting is the fact that these are relatively easy techniques. The breathing was one that obviously is done on a consistent basis. In fact, it's pretty standard for anyone who would be dealing with any kind of general anxiety issues in the schools. So I think there should be a lot more of mental health curriculum, if you would, within the schools. And I think educators understand that, recognize the importance, and they're trying to build that as well. So I think that's where they just require the benefit of all of us and cooperative learning opportunities where they can really decide what that should look like in their buildings.
Great, thank you. Well, it looks like we're just about out of time. I want to thank our distinguished panel, Dr. Churchwell, Dr. Whitty, Dr. Sloan, Dr. Shetty for that great presentation, our keynote speakers this morning, Dr. Sievert and Ms. Summerfield. I think this has been, and all of our poster presenters, which were really amazing too. So this kind of gives you a sense of the breadth of the work that really is going on at the university and in our community related to social determinants of health and how important that is. So I hope it just gets some of our discussion going. I want to thank, before I introduce her, Dr. Eileen Walsh, who has been like the major force between putting this symposium together, Kristen Gartland, Pam, all of the people, and our Cheryl, all of the people who've helped us today to really make this happen. Mark Miller up there, who's our IT guru. Thank you to all, and thanks for everyone participating. I'm going to turn it over now to Dr. Walsh.
Great. Thank you, Dane. She actually gave a lot of my remarks, but I want to take this opportunity myself to give a warm thank you to all of the speakers who are in front of me today and those who had to leave to take care of other business at the hospital. So we're still indebted to all of you for the incredible work and expertise that you've shared with us today. We are privileged that you've chosen to be with us, and we certainly hope that we'll be able to collectively help make a dent in all of the social determinants of health and really make those living breath here in the community. I do want to make sure that I thank individually the committee members. We have committee members that are present, as you've heard, Cheryl, Kristen, Mark, as well as Pam, who have worked tirelessly, and all those that you haven't seen because they're virtual, behind the scenes as moderators. So we had a great committee trying to pull this off. This hybrid event was not easy to do. It certainly was a challenge. Some of you experienced our breakout challenges today too, but we do want to thank all the poster presenters. We had a total of 19 posters. We're grateful that you all submitted those. They're wonderful topics. It was a very difficult decision for the judges, but we did have an emeritus faculty member as well as two other retired faculty who practice in the clinical arena yet judge the posters. So I did want to share that. And before I do share the actual award winners, I wanted to make sure I recognized Sigma Theta Tau, the Zeta Theta chapter, as well as Promedica, because they were gracious in donating monetary amount of money that we are providing to the award recipients. So each of the award recipients that you see on the slide, ranked order from number 1, 2, and 3, will receive a monetary sum, and I will work with them to provide it. So the award recipients are first, Kelly Clemens, Maggie Benenkamper, and Andrew Gears, and that was for income moderates the relationship between affect and open label placebo expectations and approach responses. The second place winner was one presented by Jody Jameson on mindfulness interventions in patients with cancer and updated evidence synthesis with implications for practice in the time of COVID. The third place recipients were a host of individuals, and the lead author is Roberta Redfern, and that was on the role of comorbid conditions and social determinants of health for patients hospitalized with COVID-19. So we want to thank all of the poster presenters for their gracious time they devoted, and also coming to our dress rehearsal to get the posters and interface with the computers accurate. But we do want to highlight these 3, and they will be hearing from me with thanks and their monetary awards. That really wraps up our program. We do have one last slide to share with you, and that is for the nurses in the audience who wish to obtain contact hours. The slide should come up. You can feel free to just, the chat will have the actual link. It's to a Qualtrics survey. Do you have it? Great. It's the link to the Qualtrics survey that you can use, and we have this approved for 3 contact hours. So thank you very much. Thanks everyone for attending. Have a great rest of your day. Enjoy your lunch, and we look forward to seeing you at our next College of Nursing event. Have a great day. Thank you.